So I think in case history 1, I very much promoted when to use inhaled corticosteroids, and there are things around the side of inhaled corticosteroid use that you need to take into consideration: bacterial infection, bloody eosinophil counts, frequency of exacerbations. And in the last case, you see that the outcome was favorable because the right decisions were made at the right times. Now here is a case which is very different, and we'll explore this. As a 53-year-old male who had COPD diagnosed 2 years ago. At the point of diagnosis, the patient stopped smoking. FEV1 67% predicted, working in an office, so an active person. Some limitation due to shortness of breath, and I think this is common with COPD patients. Many of them like to carry on, quite rightly, doing activities such as going to work or their everyday activities, but they slow down a bit. So this patient was able to do his job, but had stopped doing a couple of things or just did them slower than usual. Now, there was a history of chest infections with sputum production, and some antibiotic courses had been given. The primary care physician, as the first treatment, gave an inhaled corticosteroid long-acting beta-agonist combination. So I saw this patient, and I went into this in detail. There was no history of asthma anywhere, no childhood breathing problems. No doctor had ever said to this individual, "I think you have asthma." There were no trigger factors. There was nothing in the way the symptoms present. There was no wheezing that would make you think this is a diagnosis of asthma. The individual had a normal IgE, no history of allergies. So this is a smoker with some episodes of chest infections who has obstructive spirometry. The FEV1 FVC ratio was also less than 0.7. Bloody eosinophil count was 120. So actually right at the lower end of what you would think for ICS response. Now, I don't have it on the slide, but actually it's irrelevant, which is why I did not put it on the slide. The reversibility test, the individual gave 150 mils reversibility. Now, reversibility does not help you diagnose asthma or COPD in terms of differential diagnosis. Patients with COPD can pass a reversibility test. It doesn't miraculously suddenly become asthma. You need to look at all the details together. So actually what's going on here, and we see this commonly in the UK, and I'd be interested in your experiences from Spain and from India. The GP had, to coin an English phrase again, hedged their bets. They were wondering with a younger patient, well, I think this is probably COPD, but just in case I'm missing something, I've got a younger patient here, it could be asthma, I'll give an inhaled corticosteroid. When actually there was no reason to. The eosinophil count wasn't in the range where you would give as a starting therapy an inhaled corticosteroid. The main problem the patient was describing actually was breathlessness. So there should have been a focus on bronchodilation and improving the person's physical capability. So I started the patient on a dual bronchodilator. Since being under my care, we've not had any exacerbations, and actually the patient has described being much more able to be physically active. So I think this is a case that's a completely different type of COPD patient where a different management strategy was required.
Fantastic. I think clearly this patient was better after withdrawal of the inhaled steroid. Across the world, ICS-LABA has been first choice among many primary care physicians, as you know, and general physicians. And we know we can do equally well sometimes in many COPD patients with just LABA-LAMA. So both Dave and Mark, I'd like to know from you all, are there any clear patients where you would like to avoid giving inhaled steroid?
Yeah, so I'll start. just to summarize this case, I think that as a starting therapy, there's two things that primary care physicians worry about, and they shouldn't. One is the age of the patient. It seems to be that the younger age, there's more of a worry, am I missing asthma?
Right.
Well, I think you need to look at the whole clinical history. The age is not a determinant of whether you start an inhaled corticosteroid.
Sure.
The second is a reversibility test. So as soon as somebody passes a reversibility test at 200 mils, 12%, there seems to be a moving towards this is an asthma patient. Actually, all that's telling you is that the patient in front of you has responded well to a bronchodilator. It doesn't help you in a differential diagnosis. And if anything in COPD patients, it would tell you more in a patient like this who's breathless, who has some dyspnea, that patient would benefit from more bronchodilation.
Okay, that's interesting. And you would say, even if it was a 400 ml improvement, it would be the same?
Well, yes, it tells you the same thing, that the patient has 400 mils of improvement to be had if you give them proper bronchodilation. Now, so you should start with bronchodilation and then reassess the case. I'm not saying never give these people inhaled corticosteroids, but you should start with bronchodilation and see how you get on. So I've answered your question more in terms of starting therapy. I think I'll hand over to Mark.
Yes, Mark, go ahead.
Yeah, let me start with the issue that you mentioned of the 400.
Yeah.
I mean, in Spain, we had our Spanish guidelines, and we still define what was called as ACO, as asthma COPD overlap.
Right.
And one of the criteria for that ACO was this 400 milliliters increase or more in patients with COPD. However, when we look at patients in large databases with COPD that had more than 400 mLs reversibility, all of them had something else. I mean, something else meaning a previous diagnosis of asthma, high eosinophil counts, or allergies. So you never found a reversibility of 400 or more than 400 as the only sign that these patients may have some signs of asthma or would respond to ICS. And therefore, we excluded, as Dave said, reversibility from our criteria to treat with ICS a patient with COPD, because it was misleading. I mean, it by itself, it will never appear. And I agree that just a positive bronchodilator test is not a criterion. And going back to your initial question on when not to use ICS, well, I think that apart from the messages that Dave said that I completely share, we need to remember that the majority of patients in primary care, not in specialist clinics, and not also the one that I will share with you in a minute, the majority of patients in primary care are infrequent exacerbators, are milder patients who experience no exacerbations or one moderate exacerbation in a year, and these patients only rarely require an ICS, only if they are very eosinophilic or have some signs of asthma. But the majority can be managed with 2 bronchodilators. I mean, if we look at the IMPACT or ETHOS trials, so these trials showed how the benefits of ICS, but those patients had 1 admission, 2 exacerbations, but not without treatment, while they were already on 2 drugs, or in some cases even with 3 drugs. And they had a mean FEV1 of approximately 43 to 45%, again, while on treatment or inhaled treatment. So these are not the majority of patients that are seen in primary care. And therefore, to my main concern is that overuse of ICS in mild patients or in young patients, as the one that Dave had just presented, that are infrequent exacerbators and they have a long life expectancy. And if they are started on ICS, it will be difficult that any other physician will try to remove this ICS, and they may be on ICS for years or decades. And this is something that we need to avoid.
So that's it's a difficult decision always. And I think what Dave mentioned about a younger patient probably being more inclined to be perceived as asthmatic by the treating respiratory physician makes sense. And therefore, you are going to see more usage of inhaled steroid in the possible hope that you will gain FEV1 for that patient.